Either is fine. Good morning. I'm Catherine Buki. I'm one of the board members, and I am delighted to welcome everyone to our first and possibly only virtual annual meeting. I'm so grateful to everybody who is joining us today, and I missed seeing you all in person. It's my great hope that this meeting is not only a placeholder to sustain the bonds that have made this organization such a great source of camaraderie over the decade, 11 years, wow, but also a time for us to pause, to set aside the work and responsibilities that we're all managing, and to focus our attention on the rare opportunity we have to come together across the spectrum of sleep medicine and to learn together side by side from all corners of our region. This morning, I have the pleasure of introducing Dr. Helene Emsellem, a nationally renowned sleep expert. Hello. In addition to appearing on TV and radio shows and sharing her expertise through various publications and presentations, she has a great love of patient care and teaching. As a physician and a mother of 3, she has a keen interest in teen sleep awareness and has created an impressive platform locally and nationally surrounding this issue. If you have children, and if you intend to allow them to become teenagers, her book, Snooze or Lose, on how to improve teen sleep is an absolute must-read. I enjoyed it, and it saved a lot of harmony in our household. Dr. Emsellem graduated and completed her neurology residency at George Washington University, then completed subspecialty training in epileptology and clinical neurophysiology at Johns Hopkins, then returned to GW in an academic career in the Department of Neurology for over a decade. And then in 1995, shortly before I arrived in Maryland, Dr. Emsellem left academia to focus on direct patient care and established the Center for Sleep-Wake Disorders of Chevy Chase, addressing patient care, research, and educational needs of the community. She remains a formidable presence in the field of sleep medicine. And despite her ongoing contributions to research and publication and running a premier private sleep practice and lab, she has continued to find the time to serve the sleep community and to be a wonderful resource for collegial discussions that run the gamut from complex case management to sharing advice on the finer points of running a private practice and sleep lab. We're privileged to have Dr. Emsellem as a neighbor, a mentor, a willing speaker and panelist, a local asset with a national presence, and she will be bringing us up to date this morning on new drugs for sleep and wakefulness. Thank you for being here.
Thank you so much, Catherine, for that very kind introduction. I appreciate it. I have been asked to speak about new drugs for sleep and wakefulness. I'm going to pop in a few devices as well, just because it's kind of boring to go through lots of studies back to back. But it's been a very interesting couple of years here, and I'm going to go over drugs in development and a few of the drugs that have come out onto the market as we've been, like I like to describe, with our heads in the sand trying to survive this pandemic. So fortunately, some drug development has continued during this time. I do have many conflicts of interest for this talk, as my office and staff participated in many of the trials, not all of them. I've done my best to reference them, and for ongoing trials, I've just used the available information from clinicaltrials.gov for you. So my conflicts are all listed here, and this slide is references that are required from the objective literature out there regarding the topics that I'm going to cover. And this is an accredited talk, as you all know, at this point during this. So my goal here is to review current concepts of sleep-wake circuitry. As you all know, and from my introduction, I'm a hardcore clinician. I'm not a pharmacologist, and I am befuddled at times by keeping all the neurotransmitters straight. So I'm going to dumb this down whenever possible to my level so I can understand it and help you understand the mechanisms of action of some of these new therapies. And I'm going to go over newly marketed drugs and things in the pipeline for sleepiness, including narcolepsy and idiopathic hypersomnia, obstructive sleep apnea, insomnia, and circadian rhythm sleep disorders. Depending on how fast I manage to talk without boring you all to tears, we can chat a little bit about what the future may hold for sleep medicine. But all in all, it's been a very exciting time to be involved with sleep, and that's something I can honestly say since I opened the lab at GW in 1985. Always an exciting time in sleep. This is an interesting slide from Cliff Saper, published in 2001, when we were beginning to understand the concept of hypocretin or orexin and how it works. His concept was that there was a sleep-wake switch with the VLPO, the ventrolateral preoptic area of the hypothalamus, promoting sleep via GABAergic transmission, and then the adrenergic, serotonergic, and acetylcholine-related regions of the brain promoting wakefulness. He described it as a flip-flop switch, and that hypocretin was necessary to stabilize it. So you could get into wakefulness, but you had to stabilize wakefulness. You had to stabilize sleep in order to get adequate amounts of both into the day. And I'll reference this back again as we add histamine and other things to these pathways now to understand it. We now know that the orexinergic neurons originate in the lateral hypothalamus and major interactions with all of these neurotransmitter regions, as well as the cortex, and the tubomammillary nucleus is the region that produces histamine. The histaminergic neurons are only located there in the brain producing histamine, and these interact in ways that we understand a little of and are hopefully going to understand more of moving into the future. So I'm going to start off with new drugs for narcolepsy with and without cataplexy. This is the overall list of the compounds newly approved or in study that I'm going to discuss today. And we'll start off with Avadel Pharmaceuticals. Avadel's original name was Flamel, and they have a compound FT218. This is an investigational, once nightly, modified release formulation of sodium oxybate. Clinical trial is completed, and the drug is under review at the FDA. They're seeking approval for treatment of excessive daytime sleepiness and cataplexy in adults with narcolepsy. The REST-ON trial was the pivotal phase 3 trial. The results are not fully published yet, so this is a description of the trial from clinicaltrials.gov. We actually did participate in this trial. There were 212 subjects randomized. This was for narcolepsy with cataplexy. There were 3 doses evaluated, 6 grams, 7.5 grams, and 9 grams. And the co-primary endpoints were the maintenance of wakefulness test, average sleep latency, the CGI, clinical global impression, and weekly number of cataplexy attacks in the NT1 subjects. All 3 doses met all 3 endpoints with excellent p-values. The 9-gram dose was associated with the most common adverse reactions, which is true for the drug that's our tried and true Xyrem, with enuresis at 9%, dizziness and vomiting at 5.2%, somnolence, decreased appetite, and some nausea and tremor as the most common adverse events. And just to go back to this for a moment, this trial is completed. They are starting up an open label study for subjects that do want to try to cross over to the single nightly use compound. The drug is in review at the FDA at this time. Jazz Pharmaceuticals has the compound JZP-258, which is now marketed as Xywav. And this is a lower sodium oxybate compound with a mixture of salts of calcium, magnesium, potassium, and sodium. There was a phase 3 trial and the compound has 92% less sodium than the original sodium oxybate. I'm going over this mostly because this came out and got approved during our pandemic here, just as it was starting. The JZP-258 Xywav trial had 134 adults aged 18 to 70 with narcolepsy with cataplexy, and the requirement was 14 cataplexies over a 2-week monitoring period. There were 4 groups at entry: sodium oxybate alone, sodium oxybate plus an anti-cataplectic, which they were able to stay on, patients on other anti-cataplectics, and no treatment. It was a 12-week open label study with optimized titration period, and then a transition from sodium oxybate to the low sodium oxybate formulation. And this study did include a double-blind randomized withdrawal phase, which was done 1-to-1 to document continued efficacy and to look at the resurgence of cataplexy during that withdrawal period. There was also an open label study thereafter. The primary endpoint was the change in weekly cataplexy attacks from baseline. Key secondary endpoint, the Epworth Sleepiness Score from the stable dose period once the dose was adjusted to the randomized withdrawal period. And other secondary endpoints were the patient's impression of change, clinician's global impression of change, and there was an evaluation of the physical component summary and the mental component summary scales selected out of the short form SF-36 that was looked at in that study. Treatment emergent adverse events, headache 20.4%, nausea and vomiting. Worsened cataplexy was associated with the double-blind withdrawal phase, and you can see the vomiting that was reported with the once nightly sodium oxybate. JZP-258, now marketed as Xywav, was found to be effective in statistically significantly reducing symptoms of cataplexy and sleepiness in NT1 patients, that's narcoleptics with cataplexy. Worsened cataplexy and sleepiness was documented on those who were in placebo during the randomized double-blind withdrawal phase of the study. And it is of note that there was no direct comparison to traditional sodium oxybate in this study. And it was improved right in the midst of the pandemic in July of last summer. I'm going to go on now and talk a little bit more about histamine promoting wakefulness. Histamine produced in the tubomammillary nucleus, and these are the pathways where it has its influence on promoting and reinforcing alertness. Histamine neurons originate in the hypothalamus in the tubomammillary nucleus. It's the only place where these histamine-generating neurons are located. They project key brain regions associated with sleep and wakefulness. And important message here, which I think we'll learn more about over the ensuing years, is that hypocretin or orexin and histamine are complementary with similar pathways and reinforcing alertness. Histamine inhibits non-REM and REM sleep-promoting neurons, thereby augmenting alertness. and it increases daytime histamine. And an increase in daytime histamine promotes alertness and prevents daytime sleep. And again, where we see hypocretin arching over and reinforcing all this, we also now have histamine with similar functionality. So histamine is produced in these H1 neurons in the tubomammillary nucleus. The H1 receptor is on the postsynaptic neuron. And very importantly, there is an H3 histamine autoreceptor on the histamine neuron itself. Histamine is produced from histidine via histidine decarboxylase, stored in vesicles, and then released into the synapse. Interestingly, histamine lives only very, very briefly in the synapse. Increasing just synaptic histamine levels has only a fleeting effect. So we'll look at some of the mechanisms of action of this as we go through this. So H1 receptors are on the postsynaptic neuron. The H3 autoreceptors are on the presynaptic neuron. Pitolisant is the first in-class H3 receptor antagonist inverse agonist. So trying to explain this clearly for you, and the pitolisant binds to the H3 autoreceptor. The function of that H3, go back a slide. The function of this H3 autoreceptor on the histaminergic neuron is to shut down production of histamine. So when there's lots of histamine in the synapse, it binds back to the presynaptic neuron and says, let's slow down production here. And what pitolisant does is it binds to that H3 autoreceptor so it can't slow down internal production. But it also seems to have an action to increase the synthesis of histamine from histidine inside the presynaptic neuron, which is the part that's termed the inverse agonist effect. And it also seems to have an effect to increase the release of histamine from the presynaptic vesicles, also an inverse agonist effect. The net effect of pitolisant then is increased histamine binding at the H1 receptor because there's thereby more histamine being released and active in the synapse. And this is another diagram, and when you go back over the slides, it's kind of a nice diagram showing where pitolisant actually binds to this H3 receptor, but also seems to have an effect inside the cell to promote the production of histamine and the release of histamine from the vesicles. So pitolisant is marketed as Wakefulness, and it increases activation of H1 receptors, increasing communication with alerting neurons throughout the brain, promoting wakefulness. It is FDA approved and indicated for the treatment of sleepiness or cataplexy and/or cataplexy in narcolepsy. A couple of caveats about it. It's contraindicated in patients with moderate to severe hepatic or renal impairment. If there's mild to moderate impairment, the dose needs to be reduced. People who are poor CYP2D6 metabolizers or strong CYP2D6 inhibitors may need the dose adjusted. It can prolong the QT interval. An EKG with a careful look at the QT is required, and dose adjustment could be needed upward, needing potentially 50% more pitolisant if a patient is a strong CYP3A4 inducer or is on a strong CYP3A4 inducer. I would suggest everyone go to the wakefulness.com website under the portion for practitioners. If you log into that part, there's a very nice video explaining circa 2021 our understanding of how this interesting compound works. Now, under development from Subin Life Sciences is compound G3031, which is a novel selective histamine 3 receptor inverse agonist. Marketed for the treatment of narcolepsy, it's being studied, not marketed yet, for the treatment of narcolepsy with or without cataplexy. This is some information from clinical drug investigations from 2020 in a healthy subject study of young adults where there were single and multiple doses of this compound up to 20 milligrams. High percent excreted unchanged by the kidney, 60%, found to be safe and well tolerated with adverse events of abnormal dreams, dysomnia, and hot flashes. The ongoing study is looking at treatment for narcolepsy with and with cataplexy. It's a phase 2 trial, double-blind, placebo-controlled, parallel groups. This does have overnight sleep studies, baseline documentation of nocturnal sleep and MWT, and then follow-ups for 2 additional times at the end of the first and second week of dosing. It's a randomized 1-to-1 study of 2 milligrams, 4 milligrams, or placebo of G3031, evaluating the safety, tolerability, pharmacokinetics, and efficacy. And this is an ongoing trial. And the primary outcome measures are MWT change in mean sleep latency. Excuse me. Oops. Sorry for the glitch. There's an object in the middle of the slide, but we'll make our way around it. Primary outcome measures, maintenance of wakefulness change in mean sleep latency from baseline to day 14. So at the end of 2 weeks of treatment. Secondary outcome measures, clinical global impression of severity, the Epworth Sleepiness Scale, and eligibility for this trial is age 18 to 50 with documented NT1 or NT2 narcolepsy. So this is a trial that is sessioning patients now with and without cataplexy. And on to talking a little bit about new things having to do with the orexin receptors. So moving from the histamine receptor to the orexin receptor. Narcolepsy type 1 is associated with a marked loss of orexinergic neurons of the lateral hypothalamus. We're still battling the concept that orexin receptors are also called hypocretin receptors, but the receptor itself is now termed the orexin receptor. These regulate normal sleep-wake transitions and stabilize alertness. Orexin A and B promote arousal and wakefulness through the orexin 1 and orexin 2 receptors. So 2 major orexin receptors that we need to be aware of, and these compounds are necessary for normal wakefulness. This is a diagram of the connections from pharmacological reviews from early 2012. I'm sorry, from 2012, but shows the connection of the orexinergic neurons from the lateral hypothalamus, their input to the tubomammillary nucleus, cortical areas, and all the regions associated with dopamine, histamine, acetylcholine, and norepinephrine, echoing the connections of histamine as well. So Takeda Pharmaceuticals has an IV compound and an oral compound. Takeda TAK-994 is a novel orexin 2 receptor selective agonist. It promotes wakefulness in wild-type mice, and this is a mouse study that was published in Sleep in 2020, last year. There's no wakefulness in knockout mice, and it ameliorated narcolepsy-like symptoms in a mouse model with orexin deficiency. is another narcoleptic mouse model study where Takeda TAC994 activated OX2R receptors with greater than 700 times selective action compared to activity at the orexin-1 receptor. So selective orexin-2 receptor ameliorated narcolepsy-like symptoms and cataplexy-like episodes in mice in their active phase. The effect was sustained in mice for 14 days of dosing with no rebound, and there was no clear difference in efficacy between single and repeated doses. So it seemed to maintain and sustain its efficacy. And this too was an abstract published in Sleep in 2020. The selective orexin-2 receptor agonist, TAC925, was studied in a phase 1 study in narcolepsy. TAC925 is a highly selective orexin-2 receptor agonist. There were 13 subjects in this study, all with NT1 narcolepsy, randomized ages 18 to 43, 61.5% male with a mean sleep latency on an MWT of 3.24 minutes. And they had to have 2 REM intrusions on their baseline naps for entry, or 1 REM intrusion with a REM latency less than 15 minutes on the night before, as well as cataplexy. This was a 9-hour IV infusion study daily for 7 days. It was a confinement study, and the endpoints were the MWT, the Epworth Sleepiness Scale, and the number of cataplexy events. And this data was presented at the European Sleep Research Society meeting this past September. In this study, there were no deaths or serious treatment emergent adverse events. Most of the adverse events were in the higher dosing group of 44 milligrams with headache, there was also nausea, salivary hypersecretion, polyuria, which is feeling the need to urinate more frequency, and sweating or hydrosis. Overall, compound was well tolerated, and there was a marked reduction in sleepiness and cataplexy during this 7-day infusion period. TAC994 is a phase 2 human study that is ongoing in narcolepsy with and without cataplexy. There are 4 subsets to this trial. This is an ongoing study of an oral preparation of this orexin-2 receptor agonist, looking to recruit 202 subjects at 100 global sites, ages 18 to 65, and the initial dosing was 120 milligrams BID in Part A, and the dosing arms in Parts B and D, which are starting up now, is being developed based on this data. This is information from clinicaltrials.gov. The first section of Part A, I believe, is going to be presented at World Sleep later this month, but is not available right now to share with you. And the other compound for the treatment of narcolepsy with cataplexy that has been under study in this past year is Axsome's compound AXS-12. And I'm going to talk to you a little bit about the CONCERT trial. It was a phase 2 double-blind randomized placebo-controlled crossover trial of the compound reboxetine. I'll tell you more about in a moment. There were 21 patients with 3 weeks of treatment, crossing over to 3 weeks of placebo. The compound reboxetine is a highly selective and potent norepinephrine reuptake inhibitor. It is approved for treatment of depression in Europe and over 40 other countries, but not here in the US. There are positive preclinical results in narcoleptic mice models, of the hypocretin orexin deficient mouse with significantly reduced narcoleptic episodes and cataplectic episodes. This was an open label. This also had an open label pilot trial, improved sleepiness and decreased cataplexy in patients with narcolepsy on the 10 milligram dose. And this published data was 12 patients over 2 weeks. And the published data, that trial is completed, and a phase 3 trial is being planned of reboxetine for narcolepsy with cataplexy. And I expect we'll be starting up sometime over the next month or two in the area. Also like to talk to you about new drugs for idiopathic hypersomnia and JZP-258, the low sodium oxybate formulation of sodium oxybate, marketed now and FDA approved as Xywav, which has been studied for idiopathic hypersomnia. I'll talk to you about that, as well as another Takeda compound, TAK-925. So there was a multi-center study of the efficacy and safety of the low sodium formulation of sodium oxybate, JZP-258, in the treatment of idiopathic hypersomnia. And there was also an open label extension to that trial. This is the low sodium oxybate formulation of mixed salts of oxybate, double-blind, placebo-controlled, randomized withdrawal study with 154 participants, ages 18 to 75, had to meet criteria for a diagnosis of narcolepsy with an ESS greater than 11, and they had to have they were able to stay on a stable stimulant or alerting agent if they had been on it for at least 2 months prior to the study and were agreeable to staying on the same dose. 2 weeks of stable dosing period with a randomized withdrawal, and then an open label period for idiopathic hypersomnia. Primary outcome measure was the change in the Epworth Sleepiness Score. Secondary outcome measures were the percent of subjects reported as worse on the patient global impression of change or the clinician's global impression of change at the end of the double-blind withdrawal period. That study also looked at the FOSQ-10 score for quality of life and the hypersomnia severity scale from the end of the stable dosing period to the end of the double-blind withdrawal period. And this study completed in December of 2020 and is at the FDA for review now. Completed both the double-blind as well as the open label phases for idiopathic hypersomnia. I'd just like to point out this is potentially the first and only drug that may be approved by the FDA for the treatment of idiopathic daytime hypersomnia. And this is now TAK-925, the Takeda compound, which was studied in a phase 1B trial with a double-blind placebo crossover to evaluate the safety and tolerability of a single IV infusion dose of TAK-925 in adults with idiopathic hypersomnia. 2 treatment crossover groups, the Takeda 925 or placebo. It was a single 9-hour IV infusion, a 24-hour washout, and then a single 9-hour IV infusion again, once with drug, once with placebo. Patients had to meet the ICD-10 criteria for idiopathic hypersomnia, and it had to be verified by polysomnogram and NAP study within 10 years. Onset of symptoms, interestingly, had to be between ages 10 and 30. The ESS had to be greater than 11. This study was completed in 2020, November 2020, and is results as yet not published. So nothing more to say about that at this time. Like to go on, since I am burning through my time rather rapidly, and talk to you a little bit about drugs in the pipeline and treatments for obstructive sleep apnea. And just to mention here, we're going to talk a little bit about the Apnimed combination of AD036 and atomoxetine. The Takeda compound that we've talked about in trial for obstructive sleepiness with obstructive sleep apnea. Just a highlight here, the Night Balance Lunoa sleep position trainer for the treatment of positional obstructive sleep apnea did receive FDA approval in March 2018. And in the fall of 2019, just before the pandemic, Medicare approved its usage as well. And we were expecting in early 2020 to have Medicare not only assign a billing code, which they've done, but assigned a fee for the billing code. And to my knowledge, that has not happened yet. There's also this Excite OSA tongue stimulator that the FDA has recently approved. So very interesting combination of atomoxetine, which is marketed as Strattera, and oxybutynin for the treatment of obstructive sleep apnea. There is evidence that drugs with noradrenergic and antimuscarinic effects improve genioglossus muscle activity and upper airway patency during sleep. Atomoxetine is a norepinephrine reuptake inhibitor, oxybutynin, an antimuscarinic. It was a randomized, placebo-controlled, double-blind crossover study comparing 1 night of 80 milligrams of atomoxetine plus 5 milligrams of oxybutynin to placebo as a proof of concept study that was published in 2019. The genioglossus muscle responsiveness to negative esophageal pressure swings was measured by polysomnogram. There were 20 subjects, ages 46 to 58, with a mean BMI of 34.8. And the combination of atomoxetine and oxybutynin lowered the apnea plus hypopnea index in this group by 63% from a baseline of 28.5 down to 7.5. There was a documented 3 times increase in genioglossus responsiveness, improved oxygen overnight saturations, and in that trial, neither compound reduced the AHI when administered separately. Concept here is that it is possible to improve or abolish obstructive sleep apnea using drugs with specific neurotransmitter profiles administered systematically, and further study was felt to be warranted. AD036 is the Apnimed took over the study of these combinations and did a randomized 3-period placebo-controlled crossover phase 2 study comparing AD036 to placebo or atomoxetine in patients with apnea. There were 62 subjects aged 25 to 65, and the entrance criteria was an apnea plus hypopnea index of 10 to less than 20, or if greater than 20, they had to meet specific PSG criteria of a majority of events being hypopneas rather than full-blown apneas. The primary outcome measure was the apnea plus hypopnea index, and it was measured with a portable home Knox A1 device. The secondary outcome measure was the hypoxic burden determined by measuring the respiratory event-associated area under the DSAT curve from the pre-event baseline and the oxygen desaturation index. This study completed in December of 2020. The results are not as yet published, but they are planning a, I'm sorry, let me drop over. Sorry about the slides. This was completed, and they are planning another trial trying to hone down the combinations and doses and determine the most active portion of that combination. Takeda 925 was also studied for excessive daytime sleepiness in obstructive sleep apnea patients using CPAP. This was a phase 1B study to evaluate the pharmacokinetics, pharmacodynamics, and safety and tolerability of a single IV dose of Takeda 925. TAC-925, in participants with sleep apnea compared to placebo. So this was also a randomized crossover design. There were 25 subjects, aged 18 to 67. This too is completed, and the study results are not as yet published. The primary outcome measure was percent of patients with at least one treatment emergent adverse event, and this was looking at lab safety, vital signs safety, and EKG safety. Secondary outcome measures were plasma concentrations of the drug. This was a phase 1b study. And then just to touch on this tongue muscle stimulator, which was just FDA approved in February of 2021, I have to say, until I got the blast on my email about it, I knew nothing about this. The FDA approved this device that you're supposed to wear for 20 minutes once a day. It hangs on your tongue and stimulates your tongue. There were 115 patients in a study that was run by this company that has not been published in the peer-reviewed literature. There were a subset of 48 patients. There were 115 patients in total, all of whom snored, and a subset of 48 patients had snoring and mild apnea. And their study showed a 48% reduction in the AHI from 10.21 to 5.27 in the mild apnea subset. If any of you know more about this, please call me and tell me more about it. I don't know much about it, and it is not as yet available on the market. New drugs for insomnia include orexin receptor antagonists, Somryst, and there's this EB device for cooling the forehead that was developed by Eric Noxinger quite some time ago. That is on the market. And it's been on the market for some time. The concept that cooling the frontal lobes promotes sleep. It was not able to get through to anybody from the company to get literature from them. And I'm not going to touch on that further. But we'll tell you a little bit about these orexin antagonists for the treatment of insomnia. The oldest is suvorexant, marketed as Belsomra, which is a dual orexin receptor antagonist that was FDA approved in 2014 and has been on the market now for more than 4 years. Lemborexant, marketed after an FDA approval in December of 2019, came on the market last year as Dayvigo, which is a small molecule orexin receptor antagonist. And the one in study with studies that have just been completed and not as yet published is ACT 5411468, or daridorexant, which is a selective dual receptor orexin receptor antagonist. Concept of all of these compounds is insomnia a disorder of pathways promoting sleep, or is insomnia due to an overactive alerting system? So all of these compounds are trying to shut down alertness as a methodology to manage insomnia. The daridorexant study, or the Idorsia 301 study, was a phase 3 randomized, placebo-controlled, parallel group, polysomnography associated study of the safety and efficacy in adults and elderly subjects with insomnia disorder. So this was 18 and older. The insomnia severity index had to be greater than or equal to 15. Primary outcome measures, baseline to month 1 and month 3, was changes in the wake time after sleep onset and latency to persistent sleep on the polysomnogram. This was a polysomnography-based study. Secondary outcome measures change from baseline to month 1 and 3 in the total sleep time, insomnia daytime symptoms, and impacts questionnaire, and the domain score from that. This is information from the clinical trials .open.gov. We did participate in this study and its long open label extension, which is just up and finishing up now. And for whatever reason, I can't, there we go. I'm going to talk to you a little bit about, oops, I did hit that a few times. It was moving slowly. Going back to the slide, let's go backwards if we can. One more back. Okay, Somrist. So some of you may have used Shut-Eye as a cognitive behavioral therapy online program that you could sign your subjects up for. And you could actually sign your patients up for for a course in cognitive behavioral therapy. And that shut down and went for an FDA approval, which they received during the pandemic for their online digitally based CBTI app for the management of chronic insomnia. It's a self-paced 6 to 9 week program for individuals aged 22 and older. A highlight for you about this is that there is a free trial of this for your subjects that runs through the end of June, which is a good time to see how your patients like it, and that you can get on the Somrist website and find your local rep to get you into the portal so that you can sign your patients up for it. They originally marketed it at $900. They reduced the price to $600, but unfortunately, from my perspective, it's still quite a bit higher than the old under $200 price of the Shut-Eye program. But they've added quite a bit to it, and I think it's worth taking a look at it. I'd like to touch on some new drugs for circadian rhythm disorders. Tasimelteon, the treatment of the circadian rhythm disorder in the Smith-Magenis syndrome. And Tasimelteon in a new trial that is in startup phase now for the treatment of delayed sleep phase syndrome. So Smith-Magenis syndrome is fascinating. This is a rare neurodevelopmental disorder with craniofacial abnormalities, behavioral disturbances, and severe associated sleep disorder. Many patients with SMS have been shown to have a completely inverted melatonin secretion pattern that peaks during the day instead of peaking at night. So these are cognitively impaired individuals. When they're children, they're up all night and they sleep all day. Anybody who's had an infant that doesn't want to sleep for any period of time, you know how exhausting that is. Think about that forever. This is a very, very difficult group to parent, and these problems persist into adulthood, complicated by the cognitive compromise as well. There was an observational study of 8 patients with a melatonin peak between 4 a.m. and 9 p.m. with significant interpatient variability. The timing of the melatonin peak may be related to the sleep onset latency, and these studies were published in 2020. Chuck Seisler did some of these studies with a group of patients living in his lab up at Harvard. Vanda Pharmaceuticals took on, sorry about that, just swallow some water. Don't worry, I won't stop talking. Some of you might wish I would. So there was a study of the effects of Tasimelteon versus placebo in the sleep disturbances of SMS. Just to remind everyone that Tasimelteon is marketed as Hetlioz for the treatment of the circadian rhythm non-24 disorder that is seen in blind patients with no light perception. And that FDA approval was several years ago, and it is on the market as the compound Hetlioz. There were 48 participants in this SMS study, age 16 to 65. Initially, there was a 21-week double-blind portion to the study, and then there have been multiple open-label extensions of this study for the last 4 years. The primary outcome measure was the efficacy of Tasimelteon in a single daily dose of 20 milligrams 1 hour prior to the target bedtime compared to placebo. And improvement was measured in sleep parameters by patient's caregiver impression of change and clinical global impression of change with actigraphy monitoring as well. This trial was completed and was approved for, and Helios was approved for the treatment of SMS on December 1st of 2020. It is not quite, it is just on the market now. We have one subject who is in this trial who's actually gotten the drug through their insurance now. But this was a fascinating study with a rather remarkable group of both patients and parents. And the upcoming trial that is just beginning screening or began screening at some sites in March of 2021 is looking at the use of tasimelteon versus placebo in treatment of delayed sleep phase disorder. The goal is to have 300 participants aged 16 to 65 who are, for entry criteria, 2 hours out of sync with their desired bedtime and wake-up time. Primary outcome measure will be the change in sleep onset over the treatment period as measured by sleep diary. And the secondary outcome measure change in nighttime objective sleep measures by actigraphy. Change in sleep time by diary, safety, and tolerability will also be evaluated. And this is a multi-center trial that is just starting up. It will have 28 days of the double-blind randomized portion of the trial, and then subjects who are in the trial may opt to continue in 11 months of open label, which I am totally excited to see whether this will have an influence on our rather difficult night owls out there. So I am done with the slides remarkably here with a little time for questions if you like, and happy to field them now if you wish. Thank you so much for your attention. And I think there are so many very exciting reasons for us to love being sleep specialists.
Well, thank you, Helene. This is, it's always great to know what's in the pipeline. You know, we get surprised sometimes by what comes on the market, and often we hear what the reps want us to hear at the time of marketing. And it's wonderful to see what the work is, what types of questions are being asked, what the studies are looking like. I had a question to start out with. I had two. In your experience, how often does the inability to wake up for dose 2 of the sodium oxybate medications, how often does that inability to wake up interfere with the ability to optimize treatment for your patients for their cataplexy overall?
You know, Catherine, perhaps Linda Kroom in my practice can answer that a little bit better since she follows most of those patients. But I see not so much the inability to wake up for dose 2, but the desire not to have to wake up for dose 2 to be perhaps the bigger factor. I mean, if the patient is sleeping through dose 2 and they're doing okay, we often leave them alone. Many patients don't even have to set an alarm because this drug does have limited duration of action. It's very short acting, and a lot of patients waken spontaneously with the Xyrem original sodium oxybate formulation.
So when you have a drug that is causing 10%, 9 or 10% enuresis for the benefit of not having to wake up in the middle of the night, what's your take on practicality, and how much are you thinking you're going to want to incorporate that in your practice?
Oh, well, you know, there's enuresis with the original compound as well. We were a little surprised by that frequency. Dose adjustment can be helpful. Watching fluids before bedtime can be helpful. And we actually, in the trials and in our ongoing population of patients, I think historically, we've only had one patient over the many years. And we were involved with trials of sodium oxybate when it was before Jazz purchased the compound. We've only had one patient who stopped because of enuresis. I'd be interested in your experience with that as well.
We haven't seen it as a predominant factor that interferes with people's willingness. I mean, once they've gone through the hoops to get on this medication, and you know, we do ask because it is an embarrassing thing for some people to discuss, and you want to give them the opportunity to discuss everything that's interfering with their ability to have a normal quality of life. But it hasn't been the hard stop that I thought it might be. My other question to you is about cost of these medications. You know, when I first learned about Wakix, the average cost for an average middle dose of this medication is $5,000 or $6,000. For the lowest dose, maybe about $3,500, and for the highest dose, like more than $10,000. Originally, when Provigil came out, it was a cost per pill, and there was some opportunity to divide, you know, prescribe the higher dose and then cut it into bits. Any cost practicality recommendations for any of these medications that you want to pass along?
You know, for pitolisant Wakix, they do have a whole group from Wakix that will help you get your patient FDA, I'm not FDA approved, but approved through their insurance, and using their people to help you get those approvals. We have successfully had patients approved, I think, across the gamut of insurance carriers, but it takes a lot of paperwork, and they are willing to help out with it. The cost is terribly prohibitive. We looked at it for a patient who wanted to try it who didn't meet criteria, and you know, for a year it was like $20,000. So some of these things you just have to be creative and wait till we have generics.
Well, you know, it's interesting that you say you sort of said FDA approved. Oh, wait, no, insurance approved. But I think in essence, it's a very similar thing. It's essentially unavailable. I think the Hetlios is something like $21,000 per month. It just is,
But on the other side, if you're willing to fight the good fight for your patients, which I'd love to have a billing code to bill them for, just even $100 for the letter writing would be wonderful. But I mean, if you write letters for patients, we have patients with Hetlios. The blind we don't have any blind patients who have not been approved for the indication.
Super.
And we have a few patients who have gotten their insurance to cover it for non-blind, non-24. So there are a small subset of patients who have non-24-hour sleep-wake disorder or not blind. And it's a big fight, but we have gotten insurance approval on several occasions. But you can't do any of these without a good fight. You have to be willing to fight for your patients.
We have a couple of questions that I want to squeeze in here. One was, were there any common side effects noted after IV administration of any of the drugs other than enuresis? What seemed to be the biggest issues with IV administration, and why were they using IV administration? Certainly not that wouldn't be something done at home.
So this is the Takeda trial. And it wasn't enuresis. We didn't have anyone wet the bed. These patients have urgency. They go to the bathroom frequently. We didn't measure volume, but I was curious about it. It didn't seem like they were really making more urine, but they had urgency. And they didn't give a hoot because our patient was in that trial, will tell you that she was so wide awake, she was thrilled. But there seems to be a side effect of the drug itself, but they never wet the bed, and there is no enuresis reported in that trial. The enuresis was all with the oxybates.
Okay, one last question from, so the question is, with so many choices, do you have an algorithm for treating insomnia or a hierarchy of things that you try first and then move on to other choices?
Yeah, I guess we actually do. I mean, first with insomnia, we're taking a very, very careful history. I do feel that our approaches are quite different to the sleep onset insomniac versus the sleep maintenance insomniac. And I'm always pulling that middle group with multiple awakenings during the night out and worrying about coexistence of apnea in them, coexistence of REM-related apnea in the early morning hours in the sleep maintenance group, important too. With our sleep onset insomniacs, just to try to answer this 1-hour lecture briefly for you, we are big fans of lots of cognitive behavioral therapy. And I don't mind in the sleep onset insomniac combining that with very judicious use, hopefully over the short term, of a hypnotic agent when necessary. And I always point out, sleep onset insomnia is not a huge part of my insomnia population. I think the primary care physicians are managing a lot of that on their own, hopefully using as much of the behavioral strategies as we are. The sleep maintenance insomniacs at times are the bane of my existence, and we approach them again, very careful history. We screen with portable studies available now. We screen a lot of them for apnea and find apnea in a startling number of them. The literature says 30%. I think our numbers are even higher than that. And then sometimes if it's mild to moderate apnea, we have a juggling act of, and can we try treating the apnea to see if it makes the insomnia better, or are we going to have to treat the insomnia to treat the apnea? And then, you know, despite all these lovely drugs that I just outlined, I'm still a huge fan of trazodone, which I think gets dissed in the literature and everywhere else. But what we find that when we start it up very slowly and gradually, it's no longer even available as a brand name, but we start patients even as low as 12.5 milligrams. We increase them usually, once we get up to 25, we'll increase them in weekly increments. And we find a target dose between 75 and 125 when adjusted over a period of a month does not leave the majority of patients hungover in the morning and will dumb down that early morning awakening. We also do use pretty aggressive control of light during the night, shut down their crazy behaviors of turning things on, doing laundry in the middle of the night, ironing, and other things that people try to do with their time during the night, as very self-destructive and not very helpful for the management of the insomnia. So combined approaches, and then we may go to trying one of the orexin antagonists, or we may go to gabapentin for sleep maintenance as another option that's very well tolerated and dirt cheap in comparison to the other compounds, to go back to what Catherine was pointing out.
I'm looking forward to becoming known as the dirt cheap sleep specialist. Thank you. Well, a couple of the other comments were just thanking you for a lovely presentation, and I think we'll wrap this up and move on to the next. But thank you so much, Helene. It was great to see you and great to hear all of what you had to say.
Thank you so much, and don't forget to tell your insomniacs to exercise. Bye now.
Bye-bye.